Welcome to Quality Time, a Houston Methodist leading medicine podcast. I'm your host, Dr. Schaal, a clinician scientist and a retina specialist. I serve as the Chief Physician Executive of Houston Methodist, located in the world-renowned Texas Medical Center. I passionately believe that quality is the heart of healthcare. Just as a healthy heart is essential for our bodies, a commitment to quality is key for every healthcare system. Join us every month as we discuss the latest advancements in our understanding of quality in healthcare with clinicians, researchers, physicians, industry experts, and thought leaders who are as passionate as I am. Today, I'm honored to welcome Dr. Alan Lumsden. Dr. Lumsden is our Walter Fondren Distinguished Endowed Chair. He is the Medical Director of the Houston Methodist DeBakey Heart and Vascular Center, and he serves as the Professor and Chairman of the Department of Cardiovascular Surgery. All right, tell us a little bit about yourself, Dr. Lumsden.
Well, first of all, thank you for the opportunity to be here. It's a pleasure to be on Quality Time, and I think it's a great initiative, actually. So, I always say the most common question I get when I speak is, how'd you get that crazy accent? And so tell you a little bit about, I was born in Scotland. I was raised in a little town in central Scotland, halfway between Edinburgh and Glasgow. My father was the town pharmacist. There was only one pharmacist in the town that size. I mean, everybody knew him, so you got away with nothing growing up as a kid. I went to medical school in Edinburgh, and half the town turned out to say goodbye, which was 20 miles away. You know, in Houston, you're not even halfway across the metro center, to go 20 miles. So just a different scale. I'd never really planned to emigrate, and I had the opportunity to go to Emory. And I went and did general surgery residency at Emory, vascular fellowship, stayed on the faculty, became the chief of the division. Never thought I was going to leave Emory. And got asked to come down here and look at a job. At that time, Baylor was part with Methodist. And so it was the chief of vascular surgery at Baylor. That automatically meant you chief of vascular surgery at Methodist. And I said yes, largely because I wanted to meet Dr. DeBakey. And so, again, never thought I was going to move, and then ended up kind of moving down here.
Fantastic. Tell us a little bit about vascular surgery. What does this entail for our listeners who may not be vascular surgeons?
So I'm glad you asked that question. It's probably the single biggest problem that our specialty has is that branding. People often say either, you do cardiac? No, vascular surgeons don't do cardiac. Or you only do varicose veins? No. I mean, think of the way I describe it as anything to do with blood vessels from the base of the skull to the tip of the toes, excluding the heart. On the arterial side, the venous side, lymphatic side really comes into the prerogative of vascular surgery. That's kind of what we do.
And when you think about quality or high quality in vascular surgery, what does that mean?
One of the things we did here was create a department of cardiovascular surgery. Okay, that's very novel. And to go back a little bit, when I was at Emory, we wanted to create a vascular center, and nobody was thinking about it at that point in time. And the idea was we really wanted to consolidate the people who were interested in vascular disease. And so we got together with Emory Strategic Planning, and we had this beautiful business plan, which I have to this day, unimplemented. That's kind of the story behind this, was because we were going to start splitting up departments. If you were a cardiologist who did practice was mainly peripheral vascular, you were going to be in this, vascular surgery. And so we're so proud of this, and our implementation and running the politics of this was so bad. We thought a great idea was going to carry the day. We stood up in front of all these chairmen and said, we're going to take this from you and this from you and this from you. We got annihilated. And so it never happened. So really what happened here with the split from Baylor is we had a blank sheet of paper. There were no departments, there were no faculty. And so part of us having learned that lesson, you either ran from this or you said, hey, man, this is an opportunity you don't get very often. I might have failed. And so we put thoracic surgery, because it's mainly oncologic, into general surgery. And we focused our department around management of atherosclerosis or degenerative cardiovascular disease. So the department consists of heart-lung transplant, left ventricular assist device, all cardiac surgery, and all vascular surgery. So now the department does everything from the base of the skull all the way to the tip of the toes, not excluding the heart. So the challenges in running quality in this are fairly difficult, actually, because vascular, for example, vascular surgeons are not the only ones who do peripheral interventions, for example. And yet, when you look at, for example, the Vizient of this world, they bundle a set of DRGs into vascular. You and I look at that, and everybody else in the hospital thinks vascular surgery. That is not actually the case, because you got interventional radiology doing some of these procedures, you've got cardiology doing some of these procedures, and you've got vascular surgery probably doing the majority of the procedures. But managing quality across different specialties and different reporting structures can be a little bit of a challenge. Cardiac surgery is very different from that standpoint. Vascular surgeons probably do 50 different operations. Difficult to make matrices for us. Cardiac surgery does 10 to 15 operations, very standardized, highly technical. So building the quality matrices much easier in that situation. And transplant is even worse or better, regardless of what your viewpoint is, highly regulated and highly scrutinized. And so it's really very different in terms of how you manage quality in these three different components of our department.
So do you have division chiefs who manage? How do we do that here at Houston Methodist? Just talk a little bit about that.
So we divided the department up into division chiefs. And so we have a chief, Tom McGilvray, who's just finished as the president of STS, was here up until about a year ago. He was both a transplant surgeon and a cardiac surgeon. And so we kind of rolled all of that up to him. That doesn't necessarily need to be the case. It's one of the things we're debating is, do you split the transplant job into a division chief and a cardiac? I think it depends on who you get. If they have expertise in both, then we don't need two chiefs. And then Eric Peden is our chief of vascular surgery. He's responsible for managing everything from a vascular standpoint.
And I know that we have very good quality results here at Houston Methodist and low mortality, especially low if we compare ourselves to other institutions in the nation and in the world. So how do we achieve that? How does that happen? I'm also a surgeon. I know a lot of it has to do with, who do you choose? When is the time to do surgery and when is the time to say, I don't think surgery is going to help you. So how do you decide that? How do you train your people to do that?
So I think this has been an evolution, okay, and I give all sorts of credit to Dr. Boom. Dr. Boom was the VP for the Heart Center when I kind of moved down here. And so, I've had the opportunity to work with a lot of our leadership at VP level. And he's really the one who continues to beat the drum of quality. And sometimes I'm that drum that's getting beaten on because in most of the reporting matrices, it's the big piece of that. There are other pieces to it, but it's it's the single biggest piece. In a way, quality, I think, is a little bit like marketing, is that you can't go, this is great, and then you let it go.
Give us an example of something you focused on and really worked well, and how do you engage your people to do that?
Yeah, so we had a little blip in cardiac surgery mortality a couple of years ago, and so it was, how do we get the entire team engaged in it? So what we did was break down the entire patient flow from coming to the office, going to pre-op evaluation, being cleared by cardiology, education before they come in the hospital, getting anesthesia involved in this, because, this is the ultimate team sport. I mean, we run the highest acuity service, in the hospital. And so what we did was, line by line, put a name on a spreadsheet, which we showed in front of our service line and saying, Lumsden, you're responsible for that. Reardon, you're responsible for that. PAs, you're responsible for this. And every month we'd show that and go break down that matrix. How is this working? Fix it, okay? I think that accountability is a big part of this, and making sure that people understand what their roles are. And one of the challenges in an organization and changing the mentality is, we were all raised as a tertiary care referral center, which we still are. We have the mentality, we service our referring doctors and community doctors. And we have all got this mentality of, when they call, we say yes. And the thought processes of that is, you may get some really catastrophic situations sent to you, but they know you have this relationship with the referring doctors, and then they're going to send you, they send you what we call good cases or less risky cases. That's a difficult situation. I mean, particularly when you're the guy who's on call in the middle of the night and you get a call from a surgeon who's in dire straits because he can't get the patient off cardiopulmonary bypass, for example. And, when it's your partner, you want to help them out. I mean, no surgeon, particularly a heart surgeon, wants to walk from, I will say it's the longest walk. The longest walk is when you lose a patient in an operating room to go into that waiting room and tell a family, particularly if it comes in as an elective case, of what has happened. And so we understand the pressure that remote surgeons are under in a situation, and we used to say, sure, transfer them. We'd put them on ECMO, which is like cardiopulmonary bypass. But when we looked at those patients, none of them survived. So we were really doing almost a social service rather than, and those patients languish in our ICUs, and they all died. And so we kind of completely changed that policy and said, after, when they can't come off the cardiopulmonary bypass, we will not take that transfer. And that's a completely different way of thinking, because we've always thought we're the place of last resort and we're going to take those patients. But it can really affect your resource utilization, your mortality, length of stay, all of those things, which are the high bar matrices that we look at.
So you've been around there for a while. You mentioned Dr. DeBakey. I'm curious to your opinion. How did this field change from Dr. DeBakey's time till today? What are the major advancements?
Well, I'll tell you one story, which is a really cool one. What we replaced the aorta with when you sew it in is made of Dacron. Okay, Dacron was a DeBakey invention. Didn't really invent it. He actually went to a department store downtown. Some surgery was being done up in New York using Vignon N, and he was looking for this Vignon N. And the dress clerk said, no, we don't have any of that stuff. But we got this new stuff called polyester or Dacron. You may want to look at it. And so this is used for dressmaking. It was brought out. He looked at it and goes, that may work. So he buys a roll of that, takes it home. The famous pictures of him sewing this into a tube in his wife's sewing machine. They sterilized it and put it on any patient the next day.
Wow.
And so he gave that presentation. This is when I was at Baylor, actually. And, said, so Dr. DeBakey, did you get IRB approval for that? And he laughed and said, I did. I was the IRB. I said, yes. Well, that's fundamentally changed. It's come a long way. Some would say for the better, and so a lot of people would say for the worse. So, I mean, obviously medicine has changed dramatically. I think that the evolution and technology, can you imagine that the matrices, we're expected to be able to bring a patient in the hospital, open their chest, put them on cardiopulmonary bypass, which means stop their heart, do a bunch of bypasses on them, restart their heart, put them in the ICU with 1% mortality. I mean, that is unbelievable that it's been moved to the point that this is the expectation of an elective patient coming into the hospital.
Wow, it's really amazing to see how the field move forward. One thing that really speaks to me is that, we move from the age of, there is one hero, Dr. DeBakey, and then to what you talked about, team sport and having each member of the team held accountable for the result. And the best result is really focus on the patient and make sure that the patient has the best result possible. And I think that's a kind of a mindset shift that happened in medicine, certainly in cardiovascular surgery.
So, and the team's huge. And you're only as good as the weakest cog in the team. And when you think about it, is that we're completely dependent upon OR nurses. We're completely dependent. I mean, you think about an open heart case, the person who's keeping you alive is the pump, we call them the pump techs, the person who's running the cardiopulmonary bypass machine. At that point, the surgeon is basically focusing on fixing the heart. It's yet another person of the team who's actually making the flow go to your brain. And then the ICU staff, that's incredibly important. And, all the way down the line. And so, I mean, one of the things that has been incredibly helpful in giving us insight. So, for example, when the mortality changes, we look at it, okay? And we have focused relentlessly on the hospital. And so I know you've heard about HDAI. So it's a different way of getting data.
Tell us a little bit, what does that mean? What is HDAI?
So to describe it is they essentially have access to 80 million Medicare lives. And what they're doing is having real-time access to our patients, lining them up with like Medicare patients, and making these predictive logarithms about outcomes. So what that does is almost all our mortality almost all the length of stay and complications are in the top quintile, top 20% of risk patients. So number one, it helps us identify who those are, because those are the ones we need to focus on. Number two is this hospital does an amazing job, and we focus on how do we continually have to make this better in the hospital. Well, for the first time ever, they showed us a breakdown of mortality by week post-procedure. And if you look at the first week, we were like number 4 to 6 in the country. Great. Days 7 to 14 days, boom, started dropping down. Days 14 to 21 days went off the cliff. And by the time we got to 28 days, we were ranking down at nearly number 50. Well, the patient's not even in the hospital at that point in time. And so those matrices are attributed to us. 30-day mortality is basically what we're looking at. And so honestly, what it helped us say is, well, we've kind of been focusing on the wrong thing. Not that we don't continue to focus on what's going on in the hospital, but if we're going to improve this, we got to figure out how we expand care beyond that. Because as the surgeons, you're on the hook for 30 days. And, we traditionally think that out of the hospital, okay, good. We did a great job in the hospital, but the way these matrices are set up, we got to be able to expand that care. And the other piece of information that comes out of so was to be able to see a lot of these patients go to skilled nursing facility. And there was a tenfold difference in mortality depending upon which skilled nursing facility they went. And that looked like it tied into the number of our patients that they were seeing. That probably means their expertise. And so that allowed us to figure out, okay, who's going to call the patient, 2 days. But, and again, identifying the highest risk group of patient allows you to focus your resources on that group, because that's how we're going to change it. And so the cardiologist and the cardiac surgeon can't be separate. We got to figure out who's going to see the patient at the end of 7 days. A nurse is going to call these risky patients at 2 days, make sure they got all the medications. The surgeon's going to see them back basically at 14 days. They got to communicate with one another, and because we have to be able to prevent the readmissions while at the same time, improving our outcomes. And so when you do it that way, you don't have to change a lot. You make a swing of 5 to 10 patients, you change how your outcomes look massively.
Yeah, so I'm very impressed by this. You talked about evolution, also the evolution of being able to predict the outcomes of a single patient depending on comparison to database. Mm-hmm. And this is done by automatically, right?
Yep.
And then also being able to take this and say it's not only the surgery and what's happening in the hospital, but really what we do after the patient is discharged. Talk to me a little bit about other hospitals. The Houston Methodist healthcare system is not just the Houston Methodist hospitals. We have other hospitals within the community, in the regions, Sugarland, the Woodlands, and others. How do you make sure that quality is there everywhere?
So, as you mentioned, I've been here long enough to see the evolution of the system. And what I usually describe this as, after the separation, there was essentially nothing in the way of academic structure here. And really for the first 10 years, all of the focus was on rebuilding downtown. Okay, now I would argue that the cake has been rebaked. Still icing that needs to be put on it as we kind of continue to evolve this. But the focus is now turned to the system. And so that was a secondary part in the evolution, but nevertheless as important. We have as many faculty in the community now, about to be more in the community than we've got down here. And I think that's going to be, it's probably the biggest challenge that people like you and myself are going to face really over the next 5 to 10 years, because we all agree that we know Methodist is the strongest brand in this city. And patients expect to be able to go to Methodist Hospital and get equivalent care. And we have to make sure that and we're in the process of doing all this, make sure these matrices are similar. There's obviously different nuances in practice in many of the community hospitals. So you don't want to regulate this whole thing from downtown. You got to have some latitude for that. But increasingly, we're looking at system quality. We look at, from a cardiac surgery standpoint, cardiac surgery and vascular surgery is easier than cardiology. Cardiology is the big dog here. There's so many people. As a CV surgery group, we're a relatively small group of pretty close-knit people. So introducing quality matrices there is you can get 40, 50 people together and hash it out. Cardiology, probably a couple of hundred people, and a little bit more challenging because a lot more private practice related to that. But even if you're in private practice, they're all highly interested in quality. And I've been really impressed by how non-employed physicians have engaged with us in trying to move this bar forward. So I think it's a very nice model. What we did in the Heart Center is we are an open staff model, as you know. And so if you've got the appropriate credentials, you can come in and work at a Methodist hospital. What we did was the Methodist DeBakey Heart and Vascular Center only existed downtown. It started here and evolved here. Many of the CEOs wanted to have that shingle. And so what we did was we said, we want to make sure that represents high quality. And so not everybody who's on staff in a Methodist hospital is part of the Methodist DeBakey Heart and Vascular Center. You have to fill out an application. And part of that is that there are benefits, like, for example, access to a lot of the education programs, things like that. And there are obligations. And the obligations are that you agree to have your quality reviewed. And we have that scorecard for across the system by hospital. They will participate in the various different committees that we've got. For example, some of those are around quality specifically. Some are around the value analysis team. How do we jointly decide which products we're going to use? I mean, there's a huge amount of money to be saved in doing that. Probably will almost no impact on quality. And so getting people feel like they're part of it, I think we've done an okay job. But I think it's we worry about how we make people feel like they're an important part of this organization. And I'm not saying that I've got the answer to it, but that was one way of doing it. Part of it is going out to these hospitals. I mean, honestly, it's nothing like taking the time out of your day and traveling out to these hospitals and kind of meeting the CEO. And I have regular meetings with the CEO and their leadership specifically about quality issues in CV surgery.
Fantastic. I would like to end with the question that I ask all my interviewee, and that is, what does quality mean to you? When we say the word quality, what does it mean?
It means trying to get the best outcomes we possibly can for all of our patients.
Yeah. Well, thank you, Dr. Lumsden. I learned a lot from you today. It was very interesting. And I'm thanking you for coming here and being our guest today. And thank you for listening. Quality Time is a part of Houston Methodist Leading Medicine series of physician-led podcasts. So that you never miss an episode, be sure to subscribe wherever you get your podcasts. If you enjoyed our conversation today, please consider rating this episode and sharing it with your colleagues. I appreciate your support. Thank you, and until next time, I am always listening.